You're listening to Traumedy, the podcast that helps you take your pain and play with it. I'm Nancy Norton. I'm a stand-up comedian, a registered nurse, and a keynote speaker. I go around the world talking about the power of humor, why we need it, how it helps us in so many ways. There are so many benefits of humor that you may or may not know about. Some of them you know intuitively, and we explore those here on the podcast. We take heavy subjects, we lighten them up with laughter, and we make things more manageable. Traumedy is not a replacement for trauma therapy, but it will help you get by between sessions. It has helped me survive. It helps me thrive. Thank you for being a part of this, helping me heal myself and others. I am also the producer of Nurses Off the Charts, a comedy show for healthcare workers and all those who appreciate them. I mean, there's just so many hilarious stories that get shared and vicarious trauma that gets expressed. And even though it might seem like it's dark and gallows and inappropriate, it is actually helping first responders cope with their job, express vicarious trauma, have more resilience, better creative problem solving, and better job retention. People that laugh at their job stay at their job longer. Enjoy this episode. It is part one of a two-parter, and it is worth 2 parts. Our guest has some incredible information to share about trauma and about healing. She is in the healing profession. She's an occupational therapist. We're going to talk a little bit about the pelvic floor issues. She's a pelvic floor therapist, as well as so many other things. So we also talk about our mama trauma. And then at the end of this episode, you'll understand why we had to have a part 2. Thanks for tuning in. Remember to share Traumedy with a friend. Message me if you have any questions. Reach out on Instagram, nancynorton.tv, or on Facebook, Nancy Norton, or Traumedy on Facebook. Welcome to Traumedy. My guest this week is Ashleigh Tarango. She is on previous episodes of Traumedy with the quad.
Yeah.
The polyquad.
Yeah, quad on the pod.
I'm so honored you're here. We have talked a few times about different traumas in our lives, and also you are in the healing profession.
Yep.
Occupational therapist, which I admire greatly. I've known a couple of OTs, and I recognize that your education is intense.
Right.
My friend, one of my dear friends who's an OT, was just, it's so competitive, and just the anatomy and physiology, so intense of a program.
Yep.
So what is OT?
Okay. Occupational therapy. It's a rehabilitation profession. So our specific scope, like you were saying, anatomy and physiology, recovery from injury, regaining any skills that you might have lost, learning skills that you don't have. But also we have mental health training that other rehab therapists do not. So we are trained to not only take your mental health as it stands right now into consideration, and any diagnoses you might have into consideration with your rehab, but also anything that might come up from why we're seeing you. So I work in the hospital. I work in a level 1 trauma hospital. So
that's the highest acuity.
Yeah. So we're the only level 1 trauma hospital in northern Colorado, outside of Denver. And so I see a lot of car accidents. I had a gunshot wound the other day. Just any major trauma that people are there for probably an extended period of time. And so I do a lot of education about PTSD, and, I talk to patients about if they're having nightmares, if they're sleeping, if they, just making sure that they know that we have resources, and trying to normalize the trauma of why they're here being the hospital.
Yeah.
And, sometimes they might be experiencing those things, but a lot of people think, well, I was in a car accident, so of course I, don't feel good, or of course I'm not sleeping well. But that's kind of one of my roles in the hospital, is to normalize that, hey, just so you know, keep an eye out. It might not happen here in the hospital. Mm-hmm. You might have nightmares at home about being in the hospital.
Yeah.
A lot of people have medical related PTSD, and nobody really prepares them for that. So,
Man, it's so wonderful that you're there filling in that place where the nurses, we're so preoccupied with, I mean, just getting those physical needs met.
mhm.
And then there's, I could see that is just a wonderful offering to
Mhm.
people to have that insight. And also, like you said, a lot of people just think, oh, of course, I know what to expect from a gunshot wound. They don't understand what comes up with PTSD and the sense of powerlessness. And also like being in the hospital and you're on the hospital's routine now.
Yep,
There's going to be people coming in there, waking you up. It's the worst place to get rest.
it really is.
I mean, it's sleep deprivation. You're in a weird plastic bed.
Yep. You
The
have
mattress is odd.
your independence is taken away from you. There's a bed alarm. You can't go to the bathroom by yourself. You have to have a staff member help you. For most patients,
Really regresses you back to that autonomy. When we learned about those stages of development, autonomy versus shame and doubt, which I think is like toddler age. It almost probably forces you back to autonomy versus shame and doubt
yep,
phase of what are you doing out of your bed? Like
Right.
people run in there like, are you mad? Are you a mad woman?
yep. So you have a combination of people who would probably be fine going to bed on their own, or going to the bathroom, but they're there for seizures. So it's
Yeah.
like, well, you might have a seizure in the bathroom, so we can't. And they're like, I'm not going to have, like.
They don't want to bother
Yeah.
people.
And I tell people too, nobody falls on purpose.
Yeah.
And, you're here, you're admitted to the hospital. That takes a certain level of trauma and needs.
Yeah.
And it's nothing personal, but, have people fall. And that's what we're trying to avoid.
Yeah. I got to tell you, your eyes are so kind.
Oh,
I
thank
love
you.
that I'm looking into your eyes and I'm thinking, I just know what comfort you're bringing to people
That's so sweet.
because you comfort me
That's very sweet.
just
Thank
right
you.
here. Like, I'm
Yeah.
like, oh, I just sort of feel taken care of when I'm in
Yeah.
your presence. You're very generous of, being very mindful about how people receive you. And there's such caring energy that comes off of you.
Thank you. That's so sweet.
Wow.
That's something I tell them too is, been through a lot. You're here for physical injuries probably, but there's a heavy emotional toll that comes with being hospitalized for any reason.
Yeah.
And the last thing you should have to worry about is who's helping you and who's
Yeah.
taking care of you.
Wow, what a gift you are. I bet they love seeing you coming and hate seeing you going,
Oh my gosh. Well, there's a mixed bag of people.
Well, it depends on what you're putting them through, right?
Right.
Because OTs, I mean, all the physical therapists, the occupational therapists, they're the cheerleaders, and you can do it. And
Yep.
you're asking them to do things that if they're relearning, especially after a brain injury, I mean, they have to relearn how to walk, talk, and put the pants on sometimes.
Yep.
And it's a lot of work rewiring a brain. I can't seem to rewire this eye. And I know it's possible, but I got to admit, it's like after, I don't know, I did it for I think it was 3 months, and then I just got tired of it.
Absolutely. Yeah.
And I just dropped the ball. You got to keep after it, don't you? To rewire, or what is that term I'm looking for? Neurogenesis?
Yep. Neuroplasticity.
Yeah.
And I think too, now I'm like nerding out about eyes because I was also a vision specialist at one point.
Oh, really?
So I have extra vision training. But it's physical too, right? Like muscular.
Yeah.
And so,
Strengthening that muscle.
yeah.
And then just dealing with the double vision. That's what my vision therapist, I was just starting to get the double vision, which is a good sign. But who wants to?
Right.
I think my brain was like, you know what?
Yeah. I'm tired.
We can do the monocular and just tell people, look at this eye. But that was your specialty, huh?
Yeah.
One of them.
As a student, I had this awesome opportunity to work with a low vision specialist in Fort Collins at a place called Insight Skills Center. And the majority of their population is elderly geriatric conditions. So macular degeneration, glaucoma, diabetic retinopathy, that kind of stuff that can come with age.
Mm-hmm.
The aging eye, I heard somebody call it.
The aging eye.
The aging eye. So we have, as for OT school, we have to do a 12-week internship, essentially. Shadow an OT, you learn their job, and then through each week you get a little bit more responsibility. And you essentially, by the end, you are the practicing OT. they're signing off for everything that you're doing, but you're responsible for the caseload. So I spent a lot of time with my amazing mentor, Corey Layton, and just learned a lot about that side of vision. And then my next internship was in inpatient rehab. People are there for, they get 3 hours of therapy a day. The focus is on them getting better before they go home. And my mentor there was a neurovision specialist. So I did neuro, strokes, traumatic brain injuries, eye injuries, that kind of physical neurological changes that can kind of happen to anybody.
Yeah, it's fascinating to me. This makes me rub my eye. And they tell me that's the worst thing you can do after an eye surgery is don't rub your eyes somehow.
Have you had surgery recently?
The last time I had surgery, it was about 10 years ago.
Oh, okay.
9 years ago. And for about a year, it was pulled in, that muscle over here, because it left a little scarry thing that's scratchy. But they pulled it in. But then sure, as time went on, my brain just sort of said, we don't want that.
Yeah.
But it's fascinating to me. And I know I don't want to talk about my eyes the whole time, but I am dealing with, and maybe we could talk about, well, I don't want to, I've jumped subjects so quickly sometimes.
That's okay.
But I do want to talk about the wounded healer that you are and how, you became this healer that is a caregiver and some of the stuff that awakened that in you. And for me, it was, I think my mother, told me I was born cross-eyed.
Yeah. Really?
Yeah. And then tell me if I already said this. I probably said this on here. I do repeat myself. But I got these photos of me as a baby from my Aunt Nancy's collection, and she had passed on. But anyway, I'd never seen these photos of me, and they were not around the house, and I'm wondering if it was for a reason.
Oh.
But my eyes were aligned. And then about a year old, there's a picture of me with one eye going towards my nose, and I'm just like, what happened? And then, of course, during psychedelic trauma therapy, I had these memories of my mother having maybe postpartum psychosis or something and intermittently suffocating me. And I don't know if that would be enough to cause
Absolutely.
brain.
I was going to ask you while you were talking if you had some kind of physical trauma in that gap.
Yeah. I mean, I did have that memory of that happening and maybe a little like shaking stuff. I don't, it's so vague. But the knowing with the MDMA therapy, and I don't know if it's just me, but I will tell you, my therapist told me that I have, how'd she word it? You are the most intuitive patient I've ever had. So there were some things about her as well that I intuit and I start channeling now. But what I saw was my mother and my mother also having this done to her, and but she was not in her right mind.
Right.
She wasn't, I either think, I think it was postpartum psychosis is what I think.
Yeah. And I mean, that's so hard to separate, right? You want to hold the people that were supposed to take care of you accountable, but you also understand mental health.
Yeah.
And that's something that I struggle with too. With
my with your mom.
mom.
Yeah. I'll close my part and then I want to hear about your part. But like with me, of course, it's my mother, has moved on, and it makes it easier to forgive her now because I feel safe. Don't have to continue to like, am I going to get blindsided by something else? Because she did stuff psychologically as well.
Yeah.
There was some shaken baby that was psychological shaken baby, like shaken adult Nancy. Is that a syndrome?
Shaken adult syndrome? Yeah, it's called PTSD.
Shaken adult child syndrome.
Complex PTSD.
Okay. We got to write a book about this. Yeah. I think that we could co-author this. Can I illustrate it?
Right. Yes.
Can I do the
children's book?
Yes.
To learn
An adult children's book.
There you go.
What if we did write an adult children's book? I love that premise. Is it done? Has somebody done it?
Probably.
But in that same, the way children's books are done with such compassion and understanding and guide you into these stories with gentleness and ease. But as an adult child, it's like, here's what happened.
Yeah.
Okay. So, but I do know, because as a mom, I also have had to make amends to my son. I never had postpartum psychosis. I never gave birth, and I maintained a certain continuity. However, the shame that came through my body into his at times where I'm like, like that energy of like, I have to make amends. We're all doing our best. That was the end of that sentence. I know she did her best. I'm doing my best. And then we're doing our best to not send that down the on down the pike.
Break the cycle.
Break the cycle.
Yep.
And that's what you're doing. And you're doing more than breaking the cycle.
I really am trying to change the whole picture, not just break the cycle, change what it looks like.
Yeah. Do you want to say more about occupational therapy? Because I know we're going to talk about different kinds of OT, and I do get distracted by all these components. I love that you talk about the mental part of a trauma with these people, because in the hospital, we get overly focused on the physical needs.
Absolutely. What do we have to do to get this person medically stable and get them out of the hospital is the bottom line. So my job is to shake that up a little bit if I have to, right? I when I introduce myself, so my elevator speech, right? In school, we're taught to give an elevator speech because not a lot of people are familiar with OT. So I tell people, hi, I'm Ashleigh. I'm with your rehab team. I'm your occupational therapist. My job is the everyday stuff. How do we get dressed? Can we wipe ourselves? Are we safe enough to manage our medications? Do we have someone that can, bring in groceries for us because we can't lift for 6 weeks? All that stuff that maybe we do normally, but for some reason it's different because you're here in the hospital. Whatever brings you here, car accident, heart surgery, respiratory distress. Are we taking enough breaks at home? Are we monitoring our oxygen? All that stuff that we get kind of used to that is different now, or maybe hasn't been going so good even before you got here. Yep, I tell them it's my job to pick on sick people in bed, and that kind of helps them. So many people get surprised after you interview them about what life is normally like, and then you're like, okay, let's go ahead and get up. They're like, wait, you want me to, but I'm hurt. And I'm like, well, this is actually the best time to work with therapy. So, because unfortunately, pain is part of the process, and you're going to have pain at home.
Yeah.
And so if you can do it here with support, you'll know at home, I can do this. And we can problem solve ways together, have less pain, save energy. So get out of bed.
So you really have to walk that line of nurturing and kind of hard ass.
Yeah.
Like, there's like a firmness there of like, this is going to happen. Sort of like when kids don't want to go to school, and you're like, I hear why you don't want to go, but we are going to school today, and we are going to push through discomfort. And nurses, I know when I was a nurse, I would try to pre-medicate, but you can always time it, to have the medication peak about, a few minutes before you get there.
Yeah.
And
sometimes, I always talk to the nurses, and we're very interdisciplinary when it comes to rehab. I work in the ICU too, so I don't want to go and see a patient who's not medically stable. So I got to talk to the nurses, but it's also helpful for social emotional stuff. I get warnings about, they're pretty upset. We're having trouble managing their pain because maybe they take too much pain meds at home, and so we're not able to compensate here.
That's rough.
And, we hear about warnings, supportive family versus some family dynamics when you walk in.
I like how you couch that.
Yeah.
Some supportive versus family dynamics.
Yeah.
Let's just say.
Yep.
Like sometimes the hardest part dealing with family members that either don't want them to come home. Mm-hmm. Have you had that one?
Oh, absolutely.
And just like, oh no, there's no way. Like my mother, I'm like, let's bring her up again.
Please.
But when the last time she was in the hospital, she had Parkinson's, and she was 94. She fell and broke some ribs, and that was when we first started planning her euthanasia. She planned it, then canceled it.
That's a piece of the story I didn't know.
Oh, you haven't heard my euthanasia story? We got it all planned, and then my mother was like, I have an announcement. It's too much trouble. We need to cancel the death. I still have that on video. Like that? Dude, I have it on video.
It.
Yes, because my brothers weren't there, and she's like, I have 2 brothers and 2 sisters, so there's 5 of us, and the boys are the most important, of course. So she's like, I need to have a meeting with the boys here. And I'm like, Mom, the boys can't come. Different was around COVID times, and I don't remember. They had excuses. But anyway, I go, but I'll video it. So I got to get that video. My sister and I watched it on a loop for a while. Like, we need to cancel the death.
I would too.
She canceled it. But what I was going to say, she confessed to me during that hospitalization. She goes, Nancy, it was like, she did a few confessions at the end, which were very helpful to me because I wanted nothing more than to take my father home, to die at home. He wanted to go home. He's like, please, I just want to go home. I'm like, Mom, we can take him home. Nancy, she was a nurse and she had, she was a better nurse than me, I'll be honest.
Was she one of those hardcore ones, though, that starts to get that shell on the outside?
Yeah. Starts to.
Yeah.
She started off with the shell.
I mean, that makes a good nurse sometimes, right?
I know, she was. She just like, not going to be distracted by all that empathy shit.
Right.
Anyway, she just said, Nancy, we can't take care of him at home. There's no way. And I go, yeah, Mom, I know exactly. I was the home care coordinator for Queens Medical Center. I know all the stuff we need. I can get the bedside commode. I can put the trapeze on the bed. We'll put it in the family room. There are no steps. And
I can transfer him.
Yes, I can do a pivot transfer. No, we can't. And then on her deathbed, she goes, Nancy, I didn't let your dad come home because I wanted to play bridge. Now that she was in that situation, I mean, she really had that'll grow some empathy right there. Yeah. I don't know if it's empathy, but
how long had it been? How long did she sit with that?
Oh, that had been, he died in 2014. So she died in 2022. So it was, that's 6 years.
Yeah.
Yeah. But anyway, also I was helping her and she goes, Nancy, did you ever think it would come to this? And I go, yeah, Mom, it's not a big deal. You took care of me when I was a baby. And she looked at me very sad and said, I hope so. And I was like, oh. So she was trying to tell me, but I do know she did her best, even with the bridge thing, whatever. That was her best. Okay, I'm letting it go.
Okay.
Now.
You don't have to.
Meanwhile.
I'll hold it for you.
Ashleigh, I love you. You don't have to. Thank you. You don't have to. That's an interesting concept, the whole let it go thing. That's another thing we could look at later. I was like, everybody says that, but I'm like, well, how do we do that? I don't even know the tools for sure.
I don't tell people to let it go because to me, that almost says like, forget about it. And I think we learn so much at different stages in our life from the same experiences.
Okay.
And conversations like this where I tell people grow through it.
Yeah.
But, you don't have to perseverate is the word that I use a lot. You don't have to let it sit and think on it forever and bring you down. But, it's okay to remember these things.
Especially with humor, in my opinion.
Exactly.
I kind of have to laugh a little bit as I say those things. Like,
we have to cancel the death. Like, did that really happen?
Yeah.
Like, you see that in a movie and be like, nobody would ever say that.
The death. Yeah, she was removed from her own. It was like, we need to cancel the death. But back to OT, getting people ready to go home, or family members is where we were.
Oh, yeah.
Dealing with family dynamics.
Yep.
And that's another, like when you're talking about interdisciplinary, you're talking with the nurses and the PT and the whole team, the doctors, and what are the goals and how are we getting there? And all of us coordinating and.
Yep. And yeah, so I think I was kind of talking about like my role as an OT and, with my PT and speech counterparts.
Oh yeah, speech.
Yeah.
My sister was a speech.
Oh, really?
Mm-hmm.
I thought about doing speech instead of OT, but I didn't for some reason. But I'm very happy that I chose OT because of the mental health stuff. I feel like that was kind of an unexpected strength of mine, but it makes sense.
It feels more holistic too.
Absolutely. And that's one of our like key stones, like the foundation, right?
Yeah.
Of the profession.
Yeah.
Is one of them is holistic because you're not just a hip replacement.
Right.
You're not just a UTI. Maybe you.
Oh, I am. If I have sex with men. Okay, sorry. You're not just a UTI.
Yep.
You're not just a hip replacement. Yeah, like that is how nurses look. When we used to give report, we would just say, 13 bed 2, lung cancer, or whatever. We don't necessarily, like you say, you look at the whole person.
Yeah.
They're not just the hip replacement or the gunshot wound
And we all have our roles, right? Nurses and doctors, they do so much and are responsible for keeping track of so much from a medical standpoint. And my job is the functional stuff, I once had a doctor, I messaged a doctor to say, I don't feel very good about this patient going home right now. Her dementia is pretty moderate, severe maybe, and she lives alone. And the response was, well, she had dementia before she came.
So,
and I was like, absolutely, but that doesn't mean that she's safe to go home, because we are responsible somewhat.
That's probably how she ended up there, right?
Right. Right. So that was an interesting interaction for me, and not a standalone situation. We deal with that, not a lot, but have to. That's why I have a job.
Yeah.
Is to advocate for my patients, to educate them, but also to educate the staff.
Thank you for doing this.
Yeah.
Seriously.
I love it.
Even when I did home care as a home care nurse, and or case management, I did some case management, but you guys, the OTs, you do see more than we see. And I think we get kind of lazy too. I will just say, maybe just out of patterns and various degrees of burnout or whatever.
I was going to say burnout. Yeah.
So when you come in with a fresh set of eyes and, assessment, that's so helpful. And not taking those kind of answers, that you're advocating for them. You're not going to let that, hey, I'm not going to just let them go back home and fall again.
Exactly. And then they're back here. And part of everyone's job is to prevent rehospitalization. That costs money, all part of the bottom line. And OT is actually the only discipline, or it's the only service that the hospital pays for that reduces rehospitalization.
Oh.
Statistically. It is statistically associated. The hospital pays us, right? We're staff.
Okay.
And it is directly associated with decreased rehospitalization.
Well, that is not a sustainable business model.
Right? They're like, maybe we don't need it. But
we would have a lot more business.
Yeah.
No, but they need the acuity. Unfortunately, when patients drop off on their whatever acuity points, they get paid, they get reimbursed less. They don't want people in the hospital that really are at a skilled nursing facility level. So there is all this bottom line stuff.
It really, the politics of it all it's not my forte, and something I have had to grow through.
I know. Yeah.
Because it's important.
It is. It's part of it. And it is a crazy system. It's overwhelming when you start looking at the escalating inflation of healthcare. I was curious about your education. Is there a lack of occupational therapy programs? Where do you go to become an occupational therapist?
Yeah.
Those are 3 or 4 questions in there.
That's okay. I'll try to make the answer simple. It is pretty accessible from, a higher education standpoint. So considering people that already have access to that kind of education, there's lots of places all over the country to apply to. And I went to CSU in Fort Collins, which is like one of the top 10 programs for occupational therapy in the country.
And it's competitive to get in, isn't it?
It is. I got in the second time. I got good feedback on my first application and rewrote my essay and got in. But there is some, again, probably political kind of tension, because there are OT leadership people who, want to make it require a doctorate degree, like physical therapy.
Oh.
And so that just immediately makes it way more inaccessible from a price standpoint, from a student population standpoint. Like, we can't have a class of 100, I mean, they're figuring it out, but it just makes it very different, and it adds an extra year, which adds more expenses. So they tried to make that a requirement, and a lot of occupational therapy professionals were not happy and very vocal about that. So they didn't make it a professional requirement, but a lot of schools had already started transitioning in anticipation of that expectation.
Oh, wow.
So CSU is now a doctorate program.
Oh.
So I was one of the last master classes. I think there were 2 or 3 after me. So we have conflicted feelings about that.
Yeah. What's the the undergrad degree need to be in? Does it have a
It doesn't have a requirement. There are like prereq classes that you have to take. I was a sociology major and a disability studies minor. And so, but I'm like almost like a second career OT. I was older when I went back to school. I just kind of worked and lived my life and tried to figure out what I wanted to do for 10 years.
Yeah. So as the undergrad, you could have, but you had to have prereqs, probably some anatomy, physiology. Yep. I don't know what all prereqs, but you had sociology, and that says a lot about you too, the sociology degree. And were you a social worker or?
No, I thought I wanted to be a social worker. I have a lot of respect for social workers because it is way more emotional toll than I think people realize.
Yeah.
Dealing family dynamics. Right?
Yep. And they're doing their best, making the best of a bad situation a lot of times. And there's just so much frustration in the system that they have to work under.
Yeah.
When you think about people who work for Child Protective Services or even the social worker that worked for my adoption agency. And there's limitations to all of that. But it seems like OT, you've got a little bit of that social worker aspect where that holistic, what's the whole picture here?
Absolutely.
More beyond just the physical needs and the ADLs.
Yeah, that's activities of daily living, getting dressed, taking a shower, having sex, all that stuff that we do.
We don't address the sex stuff very well, at least not in my experience.
Yeah.
But anyway.
I bring it up sometimes in the hospital. I usually preface it with, you have a lot going on right now, so this might not be the first thing on your mind. Or maybe it is. I don't know.
Yeah.
But, for my spinal cord injuries, my brain injuries, even strokes, like I try not to discriminate age or sex,
Right. Don't underestimate these older people.
Exactly.
As we already know, in the nursing homes and
right.
what are those care facilities?
LTACs?
There's just so much.
Nursing?
There's a lot of STDs going around.
My God,
That's all I'm saying.
Yes.
Which is kind of cool.
Yeah,
They're getting it on. I mean, not the STD part, but you know what I'm saying.
Yeah,
I mean, it's a
exactly.
sign. It's a symptom of
it's
hopefully a fun thing for them. Although I'm fascinated. Again, tell me if we need to get back to something.
No, you're okay.
But the sexual abilities, now I have shared with you, I did go to an OT. Was she a PT or an OT? I think she might have been a PT. She was a PT for pelvic floor therapy to accommodate a penis. I'm going to say it very slowly and uncomfortably.
Okay.
A penis.
A penis.
I said
to
it.
accommodate a penis. I love that. I feel like that would be something that I would document if I was treating a patient. Patient goal, to accommodate a penis.
In vagina.
Yeah.
In the vagina. I was diagnosed with a hypertonicity.
Which is actually way more common than people think. A lot of people think hypo, which is not strong enough muscles.
Yeah.
Is a problem.
Flippity flappitis.
Flippity floppity. Hypertonicity.
Or maybe you're prolapsing at that point. Maybe your bladder's falling down. And so many people have that issue. And I never gave birth. So I don't know what the correlation is. I just imagine pushing out a baby might prolapse your vagina.
You are much higher risk for prolapsing everything.
Everything, because you're pushing so hard. On the other hand, what am I getting at here?
I don't know.
Pelvic floor therapy.
Yeah.
I am sad that I just it's a loss, that there, 20 years ago, before menopause, hey, mostly things could be accommodated. Now, I had my lesbian two decades of lesbianism where you could pick your size. I prefer this one in this color with a left twist.
I want to try one that vibrates today.
Yeah. Well, yeah. And then, what you have to, if you fall in love with a person, you kind of have to take the appendage that maybe you would call a penis, I believe is the technical term. But anyway, I'm just saying, I don't know what my point is here other than I'm grateful for people like you who are willing to help people like me accommodate a penis if they want to.
Yeah.
I haven't gotten there yet. It's kind of like my lazy eye. I don't know. There's another part of me going, you know what? How about if I just embrace the monocular vision and manifest somebody with a very small penis? Okay.
Yeah. If you want off podcast, we can talk a little bit about what your treatment recommendations were and what's working and what's not. If you want some,
that would be good.
Advice.
I'm the weakest link, as you might already know, because I'm lazy. I just get lazy. It's just trying to get you got to put it on the calendar. Every morning or evening, do a few of these exercises and start stretching things. And it's just, I always think, oh, tomorrow I better get to my Earl Grey right away. Okay. For anybody out there who's struggling with that, there's help for you. You just gotta, honestly, kind of gotta do the follow through.
Yep. And the reason, in case anybody doesn't know, that Nancy's bringing that up, other than she's very comfortable with me, which I'm happy for, is I'm a pelvic floor therapist. I specialize in pelvic health as well in the hospital and for home health. So.
Yeah, because you have your own business.
I do.
And what is it? How do people reach you on that one? I think we shared it on the other podcast with the poly quad.
We did. So my Instagram is my name, Ashleigh Kendall, so we can link that again.
Okay.
And then I work with a PT in his home health business. I'm an independent contractor, but it's Inspire Home Health in Fort Collins and Northern Colorado. So I do everything from like ADLs, people going home and just needing kind of a safety assessment. But I also do home health pelvic floor, which for the most part just looks like talking, like me and you, talking about goals, wanting to accommodate a penis and,
Without pain.
Without pain.
I know, because that is really a loss.
Not only without pain, but with pleasure.
Yeah, with pleasure.
Yeah.
The pleasure is there, but it's hard to access it when you're in pain.
Yeah.
Yeah.
And then you start to get anticipatory pain.
Yeah, and then that makes your tone tighter.
Exactly.
You're like guarded.
Yep.
Anyway, yeah.
So I actually just had a home health patient a little while ago, and I was telling her one of my recommendations for people who have this fear, right, and this hyper or hypotonicity and need to do these exercises, maybe they're practicing with dilators, is, try lighting some candles, having some essential oils,
treat yourself right.
Put on some music.
Okay.
And turn it into a self-pleasure activity.
Really that you matter to yourself. Like, I was just using my back scratcher thing, or it's like a brush. That's a long handle. And I just am so excited when
She's gesturing to her back just so people know she wasn't using it for self-pleasure. I can see her, but you can't.
I got my back scratcher.
Like, okay, don't use a loofah on your vagina, please.
Or one of those claw things. If you go to the Dollar Tree, I just got one of those back scratchers at the Dollar Tree. For people who have a lot of sexual shame and you don't want to touch yourself.
The little tiny hands on a stick.
Like a puppet. I'm not touching myself. The stick is.
This is the only way I can come.
I can't. I'm not doing it. Oh my God, that's hilarious. Oh man.
Your back scratcher.
My back scratcher. All I was thinking was the other day, I'm just in the shower, pleasuring my shoulder blades. Right. Okay, my shoulder blades. And it's a central area, right? That shoulder blade that doesn't get enough tactile stimuli. I mean, unless you're a bear outside up against a tree.
Right.
So I for the first time in, I think, my life, I was treating myself like I would a lover.
Yeah.
And I was like, oh, that's really nice to do it. Not just in such a like effective way of like, get to it, but more of a, hey, that's kind of nice.
Yeah.
And I mean, I hate that feels weird to say. Why does it feel strange to treat ourselves special, to take care of ourselves? Like, why would I treat somebody else better than I treat myself? That's kind of insanity.
Yeah.
Especially when I'm right here all the time.
Right. I have to deal with myself all the time, so I might as well take care of myself.
I mean, I do think part of this is about self-love that I haven't experienced until after doing psychedelic trauma therapy and started feeling self-love for the first time in my life. And it's like, whoa. But now I'm hoping, and this is encouraging me, to have this kind of a date night with myself.
Yeah. I thought you were going to say with me.
We can dream.
Day.
We can dream. Let me work into it, because I don't feel worthy of a date day with you, to be honest. Yeah. And it's like, I want to feel worthy of a date day with someone as wonderful as you.
We're doing it right now, just so you know.
Okay.
It's happening, and you're here, and I'm here.
Okay, we're having a date day.
We are.
Thank you.
Yeah.
Well, yeah. So this is really new to me.
Yeah.
So thank you for sharing that. I am going to do that. I'm going to make it more fun. It's not so utilitarian.
Absolutely.
And like drudgery of
and detached.
Yes. Like I'm witnessing it from a very like dissociated nursing place. Like, oh, look, you can pull this tissue this way and sideways.
The size 1 to the size 2. And
let's get to size 3 and call Steve.
Yeah. Yesterday I did 2, but now I can only do 1. And, I'm part of a couple of Facebook groups of companies that sell dilators, just to kind of get a realistic pulse on what these people are dealing with.
Do the dilators have a pulse? That's when they're good.
Yeah, right?
Those are the good ones.
Only if they're good. They have only level 10.
They come with a man.
Right. Once you can accommodate a penis. But yeah, they have so much self-shame. They have no one else to tell these things to. So thank God for them, for these Facebook groups where they can just anonymously, if they want, or they don't have much shame about sharing who they are, because nobody can see it except these other people having the same problem.
Oh, cool.
And it's like,
I'll have to ask you how to join one. Yeah. Or can my listeners join?
Yeah. So there is a company called Intimate Rose.
Oh, I do own those.
Okay.
I own a set of 4.
Well, there you go.
I'll show them to you later. They're pretty. They have different colors.
Yeah. They sent me a bunch of free samples of like dilator sets and resources and stuff.
Oh, great.
And so I joined one of their Facebook groups for their customers. So Intimate Rose is a great one. I'll have to think of the others.
That's okay.
We'll link them.
Yeah, we'll put a link in the show notes.
Yep.
Wow. Well, isn't it amazing? Like the conversation with old Nance goes all over the place. I was wondering if this is a good time, or would you feel comfortable sharing some of your trauma that lets people know they're not alone. Like you've gotten through some really intense stuff that you have shared with me before. And I don't know, were you comfortable sharing some
absolutely.
of that maybe awakens some of your compassion for yourself and others, or tell me.
And I think that's all part of it, accepting and growing through my own trauma and my own mental health diagnoses and situations is normalizing it and educating people about it. I have ADHD. One of the traits for me is oversharing, but I just run with it. If I'm going to overshare, it might as well be educational, and maybe it'll help somebody.
And one of my friends, Christy, who's on, I think, the 3rd episode, we were just talking about how we don't like small talk.
Oh,
we are so bored. We just do not even care to be in that conversation. And she goes, if you don't tell me about how your mother hurt you, I don't even want to talk to you right now.
Exactly.
So I don't know. I really feel that's a relative term, oversharing by my mother's standards or by whatever cultural standard. I do think it's okay for us to say, well, in our world, authenticity is my love language. Yep. And it's what excites me. It's what's interesting. So I want to work on reframing that too, as just the whole oversharing shame that people put on us. It's like, well, no, you're actually in the closet. Right. And you want me to be in the closet with you. And that's
actually boring.
Yeah. Beyond being in the closet.
Yeah.
You're boring as fuck.
Yeah. Yeah. So I think I agree. And I love that perspective is, it's oversharing from a quote unquote normal, standard, the
Neurodivergence?
Yeah, but the opposite.
Oh, typical.
Yeah.
Neurotypical.
I'm like, I don't even know the word. Yeah.
Neurotypical. Are you neurotypical? I'm sorry. You can't help it. They can't help it.
They can't. They really can't. You know?
We need
They
to
try.
I know. And then there's this whole, well, what I was curious about with your professional boundaries too, because I have this podcast and sometimes I think, well, I don't know if this nursing association is going to hire me for this event if they actually listen to my podcast. But back to sharing your authentic journey. Is it comfortable for you in this setting, going to who knows who, listening to trauma?
Yeah.
Right now, I have a very small reach, but I have a sense this is going to at some point get larger and larger, and then people will go back and listen to things, and it's like it's all over the place that Ashleigh
did this one thing or said this thing.
Yeah.
Yes, I feel very comfortable because, like I said, it's all part of normalization. I try not to overshare with my patients stuff that's not relevant, right? But I have no shame in relating to a patient with anxiety because I don't want to just be another person talking over you while you're laying in bed about how you should just try to calm down and just maybe not be anxious, right? Like I have panic disorder. I have anxiety. You know, I might not say it that, but I'm like, I also deal with anxiety.
Yeah.
So I know it's easy for me to say on the outside, but you know, what are your coping strategies at home? Do you have any? Like, what can we do here in the hospital so that you can participate with therapy or so that you can be able to talk to your doctors and ask them the questions that you have? Because a lot of people get really anxious when the white coat walks in.
I know.
And then they forget everything that they wanted to ask, or the doctor's saying something that they don't understand, but they just kind of go with it. So anxiety management is something that I try to normalize. And so my trauma.
Oh, I was just saying, we took a short break and I was just saying, I'm really enjoying this because I'm liking that we're talking about very serious things, but also with lightness, because this is exactly what we want to do with Traumedy.
Yep.
Like we're not taking our, I don't know, that's a triple negative.
Yep.
Let me do it. Not taking our trauma seriously. All of a sudden I developed a stutter that I've never had. But, and also the sex, the stuff around uncomfortable sex. And I got to tell you, women come up to me after shows because I talk about my dry vagina on stage. And I was doing a show for nurses and they were talking about this big breakthrough with the transplant of a pig kidney. And I'm like, I want a pig vagina. You know, can I get a pig vagina? And of course, I don't really want a pig vagina. But in fact, I'm on the side of the pig. I would donate my vagina to a pig. They don't want my old vagina. Nobody wants this. Can I be?
Now I'm so nerdy about anatomy. I'm like, what's the functional benefit of a pig getting a human vagina? Can they still procreate?
God.
Anyways.
Oh, my God. Well, and also, like, I'm just all of a sudden, I'm like, if you're an organ donor, donate your vagina to Nancy Norton. Are you a type A negative blood? And can I have your vagina? Do you have labia minora? Yeah. I have one. Left.
I mean, they did a full double hand transplant a couple years ago.
You know, come on.
I feel like.
No, I've been talking to people about hand transplants and how difficult it is to match the size and the gender and the skin. And I'm like, oh man, that's how racist are you that you don't want a black hand?
Yeah. Or your doctor doesn't even like consider it. And you're like,
oh yeah. Or if you're a person of color and you're like, that white hand would just, I don't know, man. That's a whole horror film right there.
Yeah, who does white that hand belong to, right? Like, what were they like? That's in you now.
Okay. That is complicated. Okay, maybe we didn't need to record that.
How racist are you that you don't want a black hand?
Would you take a black hand?
Yeah.
Oh, man. Okay. Now, well, I just wanted to say, it's just thank you for this gift. And as uncomfortable as it is to acknowledge in a public forum, for me to say, ouch is I think my friend George McClure said, ouch is my safe word.
Yeah, that's a good one.
It's efficient. Okay. But we were gonna, I think part of it, maybe you, I don't know, is like, okay, let's take a breath and what are you willing to share about your history that may have led you to be a healer and also a great, compassionate person.
Oh, thank you. So I'll start at the beginning. I'm just I was born in 1988.
What year were you born?
1988.
Oh my God, you're such a baby.
I guess that is actually relevant because I'm the second born. My older sister is 16 months older than me, and she was actually born with really severe cerebral palsy, CP. Schizophrenia also runs in my family a little bit, so she's minimally verbal and dependent for all her cares. So she can talk a little bit, she has her own personality, but she deals with very severe mood swings, chronic pain because she had scoliosis and she had back fusion from like cervical to like real extensive
a lot
back
of
surgery.
stuff, and then the spasticity causes so much pain.
Yeah. And so it's really hard for her to communicate much of anything. And they didn't realize when I was born that it was quite that bad. They thought she would just be like developmentally disabled because she had an anoxic brain injury. The umbilical cord was wrapped around her neck when she was born.
Oh.
She was, they had to bring her back.
So she had a near-death experience.
Yeah. Yeah. And so, the doctors were like, it's not so bad. But then she got meningitis when she was 3.
Man.
And
she got it all.
She really did. So it wasn't quite that bad when I was born, but there was a lot of already anxiety about our first child has had so much medical trauma. Like, hopefully this one is okay. Right. And then I was. So then there's kind of that, like, I'm not technically the older sister, but developmentally, emotionally, I am.
Yeah.
To her and to my younger siblings. So that's where my caretaking nature comes from, is really I was born into a situation where my sibling could benefit from my help and my compassion and my empathy. Not every sibling is like that, which is totally fine. We're all different people. But I've always been just not even need really to be asked. I was a caretaker for my sister for a long time.
You just knew what needed to be done.
I just knew what needed to be done. And, yeah, so that's kind of how it started as far as caretaking goes. And honestly, really being able to understand someone without words.
Yes. So you developed a nonverbal acute understanding.
Yeah, absolutely. And even when she is saying something, but she means something different. So understanding the complexity of language and vibes.
Yeah.
Like the vibe of the room and of the person compared to how they normally
You have a lot of intuition.
Yeah, I do.
Wow.
I absorb a lot.
Yeah.
Too, which is good. It makes me good at my job, but it makes some days harder than others. So
just a lot to take in.
Yeah. So when I used to go to summer camps with my sister, she used to go to these like camps for kids with disabilities. And these camps in particular encouraged siblings to also come. And we were all grouped by age. So every group had, a combination of siblings without disabilities and kids with disabilities that were maybe very different from what their sibling had. So it was a really good exposure. So I grew up doing that every summer. And then I started volunteering when I was a teenager. And that's actually how I discovered OT.
Oh.
Because OT also does adaptive sports. And so we had an adaptive summer camp, and OT's there to like help people fix their wheelchairs and help, manage safety and all that.
So you're like, I know all this stuff already.
Yeah,
exactly. Like nothing surprises you. You've seen so much.
Yep. I've been wiping butts since I was 7 years old.
And it's just
that weren't mine.
That were not yours.
Yeah.
That's amazing. And that it just became, like a lot of us once, at first, I know one of my friends I was just talking to, he said, I remember talking to you in nursing school and you're saying, I'm doing okay with blood and urine, but I'm still working on poo. Like, anyway, but you were just like, yeah, just another part of life,
yep.
Not a big deal. And
yep. And I tell people that at work too. It's like, I know this is very weird and maybe feels, undignified for you. You're embarrassed, you're in pain. But, I'm here this is my job. I'm here to make sure that you know how to do this. Go to the bathroom. I'm here to make sure you can physically wipe yourself because you're going to have to do it at home.
Yeah.
Or I'm here to teach you how to do it.
Or how to install a bidet. We got to do.
Exactly. Everyone should get a bidet, especially if you're going to have spinal surgery. Please get a bidet.
I said bidet, sir. Yes.
Yes.
Okay. Oh, that's good to know.
Yes.
A bidet. I know when my mother, and I mentioned her earlier, and she had Parkinson's, and at one point she fell and broke her humerus. And so, yeah, that's when we got a bidet for her. And it, oh my gosh, that, you talk about improving somebody's quality of life with a simple tool. Okay, so you grew up in this family where you were a caregiver for your older sibling who had complicated disabilities, cerebral palsy and other mood disorders or mood swings. I don't know if you call it a disorder, but.
I mean, at this point, honestly, it's best guess. My younger sister and I have actually been, through our own mental health journey. So I won't speak for her, but for me personally, I found out that I have bipolar disorder, I have ADHD, and I have a brand spanking new diagnosis called PMDD, which I would love to share with everyone.
Yes, I don't know, PMDD.
Yeah, it's a hormonal condition called premenstrual dysphoric disorder.
Oh.
So it's PMS on crack.
Oh, man.
And
I'm so glad you're not PMSing today.
I'm not.
Or would you be here if you were? I don't know. Would you have to cancel?
No, I've got it managed.
You work through it.
Yeah. And I thankfully don't have as many physical symptoms as a lot of people who have it do.
Yeah, tell me more.
It's been described to me as an allergy to estrogen.
Whoa.
Yeah. So essentially, I imagine that my nervous system just kind of freaks out whenever my estrogen changes.
So when we're premenstrual, this is I never did well with hormones because it's so complicated.
It really
the
is.
cycle.
It's called the luteal phase. Right before your first day of like menstruation where you bleed, 7 to 10 days before that is the phase where if you have PMDD, you are the most vulnerable to extreme mood swings. Actually, something like 30% of people who are assigned female at birth that are diagnosed with PMDD have suicidal ideation, and there's a much higher population of people who actually complete suicide.
In that time period,
in
the
that,
luteal phase.
In that, I don't know necessarily if it's probably, because that's when it gets really difficult, but, the shame comes after that. So you have a bad episode with irritability, with emotional dysregulation, really bad physical symptoms, dissociation. People, actually, bipolar disorder is often misdiagnosed with PMDD.
Oh, interesting.
So it's kind of like having manic episodes where you're just not acting like yourself. And so you have those where you just feel like that's your reality, right? Even if it's not everybody else, that's your reality.
Yeah.
And so then when that comes down and you're kind of back to normal, you have all this shame and guilt and emotional pain about what you did, what you thought, a fight you had with your significant other. So it can get pretty heavy for people.
Yeah. I remember 3 to 5 days before I would start my period, life was too hard for me.
Yeah.
I just life's too hard for me. And now I don't know that I had suicidal ideation, but I mean, there was a sense of this is just too hard for me. And I finally I just started taking St. John's wort, which is a natural antidepressant. And I found that helped me with that phase. And I also exercise is one of my kind of runaway. I don't care. I'm running away from that. But if I give myself energy by running or honestly putting myself through something that's really difficult.
Yeah.
I know that's weird, but it's like I would I would run the 10 or 12 mile run on the weekend. That's somehow going through that discomfort was like, okay, I can handle that other thing. I don't know. Plus, I think you get endogenous morphine, the runner's high.
Absolutely.
So, so I don't know. I mean, that's how I remember. And I remember saying to other people, and I've said, I mean, hormones change the way you think, not just like a history of situational stuff, but the way you think about things.
Yeah.
What are you?
And like I said, that's your reality. How do you fight that, especially if you don't know, right?
Like, and I did start noticing that I go, okay, wait, you know, like I could put it in a context of just wait 3 to 5 days. It's going to be okay. And just tell myself I can wait 3 to 5 days.
Yep. So that was kind of my problem, was I felt like my moods were cyclical, but I didn't track my periods. I wasn't really tracking my symptoms or anything. And then I had the bipolar diagnosis. So I was like, okay, maybe it's, you know, just that. Just that.
Just that. One of the hardest things to deal with.
Yeah. But that's, when you talk about antidepressants, that's actually the first line of treatment for PMDD.
Oh, it is.
And so I was already on Zoloft, sertraline. So we increased that, which helped a little bit, but I was still dealing with the depression and the guilt and the aftermath. So we increased my mood stabilizers, and now I'm in a good place.
Yay.
So I can still process, you know, I still hold accountability for myself. I still struggle with things, but it's not my baseline, which was down here, way down, is now at a manageable level.
That's wonderful.
Yeah.
And knowing what you need to put in place to take care of yourself too. Like right now, I don't have a significant other, and I got to admit, it's easier in some ways. I like having somebody in my corner, though, and you have wonderful partners.
Yeah.
You're lucky to have multiple partners so that, you know, or if you need space, maybe your partner can go to one of the other partners' place for a little while and give you a sanctuary. I don't know. Do you find it easier to be, what do you need when you have PMDD? Do you need more time alone, or do you need more time with somebody just reassuring you, or what is it vary?
I think it probably varies. It's super new for me. You know, my psychiatrist that I see that helps me manage my medications for ADHD and bipolar told me in the last year, you know, I think I mentioned something about my period, and she was like, okay, let's watch that, because, you know, you're at a higher risk. There's like crazy overlap between bipolar and PMDD. Actually, I have an OT student that's been shadowing me, and he's going to be my full-time student in the summer. But when I was explaining to him, you know, I applied for disability at my job. Like, it is a thing that people have to take FMLA for. Like, their symptoms get so bad. How am I supposed to interact with patients if I can't stop crying?
Yeah.
Just, you ever had one of those nothing's wrong, but you can't stop crying?
Yeah.
Like, I had that on the way into work a couple months ago, and that was kind of what triggered this diagnosis.
Yeah. What's FMLA?
Family medical leave.
Oh.
So there's like a new-ish, it's Colorado specific thing, I think, where instead of using your PTO that is for, quote, normal sickness or vacation, you have 12 weeks from the state specifically for your disability.
Oh.
So if I have to call out of work because of my PMDD, then I contact, you know, my case manager for that, and my PTO isn't used. It's money from the state that they actually pay me.
Oh, that's great.
So
you get support.
I get support, and my job is protected because I was calling out a lot, like several times a month.
But now you've got it manageable.
Now I hopefully have it in a managed space.
Yeah.
But I was explaining to my student, you know, I'm very open about this stuff, but you also kind of have to be when you're like one-on-one with somebody.
They're going to see it. I know when I was a preceptor, and those were hard for me, because I do a lot of rapport each room, and I don't like the feeling of somebody seeing that. For some reason, it wore me out. Well, because I notice it, I don't notice it until they're there. I just started noticing, like, I really do establish rapport with each person differently and try to meet them where they are.
Yeah.
Like, I'm a mutable sign.
That's a skill.
It is a skill. And I think it's a survival skill, probably from growing up with my mom.
Yeah.
But it is like, it's, you know, I'm adaptable. But it was weird. Like, part of me is like that. And then also the time in between where you just need to go offline, and but that person's still there.
Yep.
Oh man, it's tiring.
Yep.
To not that you don't want to teach people, but that's
Right.
a lot to do.
It is.
So thank you for doing that, because that can be exhausting. Like, and how do you just say, you know what, I need 5 minutes to just not be on.
Yeah.
Like, because engaged with somebody, like those recharge times between, even just that little bit of time between patient's room, where now you've got this person who's, what do you call the preceptee? What do you call the person?
Student.
The student.
Yeah.
Yes, you call them a student. I've heard this term. Yeah. But you're in between rooms and you're like, now let's deconstruct what we just did. And it's just, wow, it's a lot.
Yeah, it is.
But anyway.
But yeah, so I sat down with it. I'm very lucky with this student. All students are great. All students deserve teaching and mentorship. But this student in particular he's already a retired veteran. So he's had a whole career. He has a family, so he just kind of has that general ability to interact with people that some younger new students don't necessarily have.
Oh, yeah. Yeah.
And so I was like, hey, I'm going through this right now. I was applying for the disability thing, and I was like, I don't know. My medications were changing. So everything wasn't quite figured out yet. So I was like, I just want to be open with you that I might have to call out sick for this condition, and kind of here's what it is. And he was like, at the end, he was like, man, so you have to, with the bipolar and the PMDD, it's like hormonal and chemical for you. So it can really come at you from any direction, because bipolar is not on a timeline like PMDD is.
Yeah.
And I was like, thank you. Yes.
Yeah. That's, good for you that and that's great that hopefully if somebody's listening and they can go, wait a minute, I have some of those kind of feelings, and we all have heard about PMS.
Right.
But this is to another level.
Yes.
Right.
Yep.
And was there something else that you wanted to share? We were talking about your childhood and your development and being a caregiver with your sister, and then that's where we were.
And then
and then what happened?
So talking about moms.
Yes.
I have a podcast episode. Is it okay to shout out?
Oh yeah.
I actually have a podcast episode about a particular trauma in my life on a show called The Vanished.
Obviously, the name of the podcast was The Vanished. Mm-hmm. So she disappeared at some point. Okay, we have to leave it there for now. That is the beginning of part 2 with Ashleigh Tarango. I want to thank Ashleigh Tarango for part 1. That was a lot of great information, and we'll put things down in the show notes if you want to see references. And then tune in next week when we find out about Ashleigh's mother's disappearance and how a psychic played a role, and how one person's closure could be somebody else's trauma. So tune in next week. Learn to laugh, play with your pain, or make your trauma more manageable. And if you need trauma therapy, please go get it. Remember to share Traumedy with a friend who may be isolated. Other people have gone through some of the same things you're going through. Every Tuesday, a new episode. It's Traumedy Tuesdays. No matter what, keep laughing.